In this scenario, damage control surgery. I'll quickly finish this one, okay? If we get a patient like this, the concept is to save life first. First life, then limb. Life is very easy, no? Head, neck, chest and abdomen. Head, neck, chest and abdomen, life. Then limb. Forget about the limb. Okay, patient can live without limb. But patient can't live no without life. Okay, so head, neck, chest and abdomen. Okay. In this case, if you are going to do any intervention, it is called damage control surgery. The term you should know. What do you mean by damage control surgery? Is, you know, in 70s and 80s, warships. Okay, in the war, naval war, warships, and during the war in the middle of the sea, the ocean or sea, warship get damaged. Okay, so what they do is we try to repair the ship and then repair and again and again try to repair the ship and continue. They want to continue. But repeatedly what they have identified that totally that's a failed mission. It means while they are repairing the ship, they lose the ship, sink. Then they come to the conclusion, okay fine, we just stop repairing the ship in the middle of the sea, right? We just only do or prevent sinking. Just do something, okay, not to allow water to come inside the ship. We do later the sort of things. With the help of after doing like that, with the help of another ship, bring the ship to the port and repair outside. Okay, so they have identified in 1780s that is called damage control surgery, just to save the ship from sinking only. Okay, no AC repair, no engine repair, nothing. Same concept in 80s and 90s, they have introduced to the surgery, damage control surgery, same concept, damage control surgery. In this scenario, first do something to restore the physiology, not the anatomy. Restore the physiology, not the anatomy. Do something to stop the bleeding, do something to prevent contamination, and do something. Open the abdomen, bleeding, patient's unstable, we can't just resect and anastomose and do all these funny things, hours and hours. Put the clamps, stop the bleeding, close the tummy, put the patient in ICU, restore the physiology. After 1 or 2 days, with the patient to the theatre, then do the, if the patient is okay, do whatever you want. Okay. Damage control surgery, right? And then ICU management, okay, whether from patient goes from the A&E to ICU or after theatre to ICU, that's an ICU care. So communication is important, and it should be a closed loop communications. Okay, no one can run alone. It's a team effort. Pitfalls: don't rush for CT, don't use pelvic bleed. All cases I have discussed with the real cases, right? Avoid hypothermia, that's fine. Reassess repeatedly. Missed internal bleeding, delayed airway control, hypothermia, over-resuscitation, poor communication. Okay. Call for help. Talk to the others. If the surgical patient issues, I'll talk to Dr. Anfas, I'll talk to a pediatrician. Okay, something is like that, I'm missing everything. There's no ego. It does, if I'm asking to somebody, if my SHO is talking to the medical SHO, if my SHO is talking to the gynae SHO, it doesn't mean that he doesn't know, she doesn't know. Okay? It doesn't mean like that. Everyone has the same knowledge. All came through the same path. Okay, but we have some more experience on that field. But we just called them to ask, can you find out anything like that? In my ward, there are any issues, medical issues? I just put a medical referral code to the Dr. Anfas, so I call the pediatrician or the gynae. Would you mind look at this patient? Okay, why? Because he's an expert on that field. Not me. My field is the surgeon. Understand? There shouldn't be any ego, no complexes, nothing. Right? Take home message. It's a structured approach to slice. Prioritize physiology, not anatomy. That's a damage control surgery. That is the purpose of prioritizing the physiology. Is the purpose of doing primary survey. Goal of primary survey to identify the life-threatening injury. One, and and stabilize the patient. Okay, and reassess. So if everything is done, then only patient comes to the board. If the patient 100% perfect, only the patient comes to the ward. But in our setup, other way, from A&E to the ward, from ward to ICU, or ward to theatre, you see how it comes. It can't help because in our system is like that. We can't blame on anyone. Okay, I'm not blaming or finding fault. That is our system. Okay, so it should be in a different path, right? So if the patient comes to the ward, that's the patient stable enough, no more further intervention. Just monitor it. Okay, so follow the ICU or theatre, what do you call, up note or the handing over. That's also not done properly here. Okay, they just put the patient here and they finish and no PhD, no notes, nothing. Then what to do? So you do not right. Any questions?